Obesity. The learning objectives for this module include: explain the health risks associated with obesity, discuss nutritional therapy and exercise plans for the obese patient, describe the different bariatric surgical procedures used to treat obesity, describe the nursing management related to conservative and surgical therapies for obesity. Obesity is an excessively high amount of body fat or adipose tissue. It results from an imbalance between energy expenditure and energy intake from a long-term sedentary lifestyle and/or excessive caloric intake. Obesity is a huge problem within the United States. More than 35% of adults are currently obese, and it is projected that by 2030, 50% of Americans will be obese unless they change their dietary habits. 68% of adult Americans are within the overweight obese category. Obesity is the most common nutritional problem and the second leading cause of preventable diseases. The majority of obese persons have primary obesity, which is excess calorie intake over energy expenditure for the body's metabolic needs. Secondary obesity, which can result from various congenital anomalies, chromosomal anomalies, metabolic problems, or central nervous system lesions and disorders. The most common measure of obesity is the body mass index, or BMI. It is the degree to which a person is classified as underweight, a normal weight, overweight, or obese. It includes weight to height ratios.
Weight circumference can also be used to classify obesity. Patients who have visceral fat or truncal obesity also have an increased risk for cardiovascular disease. This would typically be found in men with a waist greater than 40 inches and women with a waist greater than 30.
The waist-to-hip ratio is another tool used to assess obesity. This ratio is a method of describing the distribution of both subcutaneous and visceral tissue. The ratio is calculated by using the waist measurement divided by the hip measurement. A waist-hip ratio less than 80 is optimal. Greater than 80 indicates greater risk for health problems. People with more visceral fat are at an increased risk for cardiovascular disease and metabolic syndrome. This is the preferred tool when the patient is predominantly muscular. Body shape is another method of identifying those who are at a higher risk for health problems. Individuals with fat located primarily in the abdominal area have an apple-shaped body, have android obesity. Those with fat distributions in the upper legs have a pear-shaped body or gynoid obesity. Genetics have an important role in determining a person's body shape. Weight and shape are also influenced by genetics. People with pear-shaped body typically have better prognosis, but seem to be harder to treat. Obesity is caused when energy intakes exceed energy output, meaning that you take in more calories than you burn. There is strong evidence that there is genetic predisposition for obesity. There are also other environmental and psychological factors that influence obesity. For our generation, there is greater access to food. We have many prepackaged foods, fast food restaurants, soft drinks, and we have increased portion sizes. We also have lack of physical exercise. There's lack of exercise at home and at work. There's advances in technology and labor-saving devices that make physical activity, physical work in many work fields less laborious. We spend increased time watching TV and playing video games as well. There's also an emotional component of overeating. Many people report that when they are stressed or depressed that they eat more. People use food for many reasons, some as coping mechanisms, some as rewards. There's also an important social component of eating, and that is developed early on in life. And you see this at birthday parties, holidays, different cultural, ethnic, and religious activities are often based around a meal and different types of maybe desserts or candies. Mortality rates rise as obesity increases, especially when obesity is associated with visceral fat. For obese persons, mortality rates from all causes, especially cardiovascular disease, are increased by 50 to 100% above those persons with a normal BMI. In addition to these problems, obese patients have a reduced quality of life. Most of these conditions can improve if an individual loses weight. This image can show you all the health risks associated with obesity. When assessing a patient's health history, some important questions to ask may include the time of obesity onset. Do they have any diseases in their past medical history that are related to metabolism and obesity? What medications are they on? Do they have a history of gaining weight, losing weight? Are they interested in losing weight? Can they identify any contributors to their weight gain? What impedes their weight loss? What are their eating patterns? How do they use food? Do they eat more when they're stressed? Do they have comfort foods? Are there other family members that are overweight? Can they identify any environmental or genetic factors that have influenced weight gain? And then you also want to include the objective data: height, weight, BMI, skin fold thickness, waist circumference. We can evaluate the patient's thyroid function and their fasting glucose level to see if there are any effects on weight gain. We can also do tests to evaluate the effects of the obesity on the person. So we would look at liver function tests, fasting glucose, and lipid panels. Listed here are just a few potential nursing diagnoses for an obese patient: imbalanced nutrition, more than body requirements, impaired skin integrity, ineffective breathing pattern, chronic low self-esteem, health-seeking behaviors, and readiness for enhanced knowledge. When developing nursing interventions for your patient, it's important to set realistic and healthy goals for weight loss. It is recommended that the patient lose 1 to 2 pounds per week, and you want to let them know that slower weight loss usually ends with better cosmetic results. They should know that plateaus of weight loss can last from several days to several weeks. They should not weigh themselves daily. It's recommended that they weigh themselves once a week with similar clothing at the same time of day. Patients need to be taught how to modify their eating patterns. They need to know they should include food from the basic food groups. They may be put on specific calories. 800 to 1200 calories is considered low-calorie diet, and less than 800 is considered very low, but is typically not sustained on a long-term basis. Persons on low-calorie and very low-calorie diets typically need frequent professional monitoring because they are at risk for nutritional deficiencies. They need to make sure they have adequate amounts of fruits and vegetables, lean meat, fish, and eggs in their diet, and they should be discouraged from following fad diets. Because our portion sizes have increased so much, patients often need to know the appropriate size for food portions. So they can be taught that a serving of fruit or vegetable should be the size of a woman's fist or a baseball. Serving for meat should be the size of a person's palm or a deck of cards. Serving of cheese should be the size of a thumb or 6 dice. Exercise is an essential part of a weight control program. Patients should exercise daily, preferably 30 minutes to an hour each day. It is important that we recommend sensible forms of exercise, such as walking, swimming, cycling. People who are on a weight management plan are often encouraged to join a group where others are also trying to modify their eating habits. Many self-help groups are available and offer support and information on dieting tips. In addition to dietary changes and exercise, certain medications are also used to help increase weight loss. Nutrient-absorbing or blocking drugs are used, and they block the fat breakdown and absorption in the intestine. Typically, undigested fat is excreted in the feces. There's also appetite-suppressing drugs. They decrease food intake through neuroadrenergic mechanisms in the central nervous system. Bariatric surgery has become a viable and popular option for treating obesity. Surgery is currently the only treatment that has been found to have a successful and lasting impact for sustained weight loss for severely obese patients. In order to qualify for bariatric surgery, an individual must meet the following criteria. They must have a BMI of greater than 40 with one or more obesity-related complications such as hypertension, diabetes, heart failure, sleep apnea. They must be 18 years or older, understand the risks and the benefits. They have to have been obese for greater than 5 years, have tried and failed to lose weight, have no serious endocrine problems. They must have psychiatric and social stability, and typically that's because most insurance companies will not cover the cost of the bariatric surgery. They must have the availability of a team of healthcare providers, and the physician completing the surgery must believe that surgery would either decrease or eradicate high-risk health conditions. There are a variety of surgical interventions available for the obese patient. Adjustable gastric banding has a band that encircles the stomach, creating a stoma and a gastric pouch with about 30 milliliter capacity. The vertical sleeve gastrectomy removes about 80% of the stomach, leaving a sleeve-shaped stomach with 60 to 150 milliliter capacity. Vertical banded gastroplasty has a band that is placed around the stomach, and staples are used above the band to create a small gastric pouch. In the biliopancreatic diversion, 70% of the stomach is removed horizontally. There is anastomosis between the stomach and the intestine. This decreases the amount of small intestine available for nutrient absorption. The Roux-en-Y gastric bypass is restrictive surgery on the stomach creating a pouch. The small gastric pouch is connected to the jejunum. The remaining stomach and the first segment of the small intestine are bypassed. Patients who have achieved weight reduction often have excessive skin folds or fat. They often choose cosmetic surgery to reduce fatty tissue and skin folds. They may have a lipectomy, which is performed to remove flabby folds and adipose tissue, or they may have liposuction, which will help contour the body and will also remove excess adipose tissue. Prior to surgical procedures on the obese patient, it must be known that the patients are likely to suffer from other comorbidities, such as diabetes, altered cardiorespiratory function, abnormal metabolic function, and atherosclerosis. So oftentimes there is a team approach that is needed for these surgeries. So in addition to having the surgery who's performing the bariatric surgical procedure, there will be a cardiologist, a pulmonologist, possibly a gynecologist, gastroenterologist, or other specialists either present during the surgery or available as needed. It is important to plan for your bariatric patient. So you'd want to make sure you have the room ready for the patient by having a larger blood pressure cuff, a larger gown. They'll need a bariatric wheelchair. You want to make sure that they have a trapeze over their bed so it can assist with movement and positioning after surgery. Wound infections post-surgery are a common complication, and this is typically because of the many flabby skin folds, especially in the abdominal area. So preparing the skin and the surgical site is extremely important. It may be necessary to begin bathing or showering the patient frequently several days prior to the surgery if they're in the hospital, or instructed to do that at home prior to their hospital admission. Obtaining venous access may be complicated by excess adipose tissue. A longer IV catheter may be helpful to go through the overlying tissue to the vein. Obesity can also make breathing shallow and rapid, so you want to make sure you instruct the patient on proper coughing techniques, deep diaphragmatic breathing, methods of turning and positioning to prevent pulmonary complications, such as keeping the head of the bed elevated, to reduce abdominal pressure and increase lung expansion. So post-operatively, you will do all the same assessments you would do for anybody who has an abdominal surgery. But we want to remember that there will be an emphasis on respiratory complications. We will focus on pain management. There will be early ambulation to get the patient moving to prevent complications. Generally, we want them to ambulate 3 to 4 times a day. They should have on pneumatic compression devices, elastic compression stockings, or elastic wraps. And then they'll need special teaching for the diet that they'll need to be on, which will vary depending on the type of surgery that they had. Generally, they will be prescribed a diet that is high in protein, low in carbohydrates, low in fat, low roughage. They'll typically need to have 6 small meals, and their fluid should not be ingested with their meals, and typically it's restricted to less than 1,000 milliliters of fluid per day. There are some long-term complications that can occur. Several of these occur because of the decreased amount of caloric intake and the types of food that they're allowed to eat post-surgery. So this can include anemia, vitamin deficiencies. They may have diarrhea. Several potential psychological or psychiatric problems can arise after surgery. Some patients express guilt feelings that weight loss was achieved by surgical interventions rather than by weight loss, reduce of dietary intake and exercise. They have increased risk for peptic ulcer formation, dumping syndrome, and small bowel obstruction. The prevalence of obesity is increasing in all age groups, including older persons. It is more common in women than men. It is typically caused because of a decreased energy expenditure and loss of muscle mass. It can also exacerbate age-related problems such as arthritis, incontinence, hypoventilation, and sleep apnea.